The Indian registry showed the in-hospital data is around 7 to 8.5% compared to almost half of what is happening in high-income countries. The long-term mortality is very disappointing. 1 year mortality of 22 to 30%, 3 year of 45, 5 year of 59, 10-year data we have presented from the Trivandrum Heart Failure Registry. It is a dismal 83%. So we know the guideline directed therapy has changed, and now we have the array of therapy, the four pillars for heart failure with reduced ejection fraction, which actually prolongs the life of a 55-year-old man by 6 to 7 years. So that is the importance of this therapy. And we have other therapy with disease devices for atrial fibrillation, iron deficiency, etc. That will also improve the quality of life. So, coming to guideline directed therapy, which is the key aspect, there are three aspects we have to consider. The first is we have to give all the four drugs in heart failure with reduced ejection fraction. They should be given at the target doses or the maximum tolerated doses. Time to initiation and optimization of the dosing, it should be within 6 weeks to 3 months. So, are we doing this? We will see the data. So this is the data from the Indian registries. Only 25 to 47% of the patients receive all the three components of guideline directed therapy, which the registries at that time only three drugs were there. Only for 25 to 47% received. And do we give at the target doses? Absolutely not. This is the data from the West, the CHAM registry, showing that even at one year, only 10 to 27% of the patients are receiving the drugs at the target doses. So all the answers to all the three questions are: we are not doing adequate, we are not providing adequate treatment as required. So why we need heart failure clinics is the answer to this. We know that we from the last 2 decades, from diuretics only to now, we have an array of devices and drugs. We have already seen 6.5 years survival more in a 55-year-old man with heart failure with reduced ejection fraction. Our aim with an heart failure clinic is to improve the guideline directed therapy and thereby improve the mortality and also quality of life. So we should also understand one fact that target doses are difficult to achieve, mainly in Indian patients due to the low body weight probably. And we know that many patients have low blood pressure, etc. But we should know that if we try to go to a maximum tolerated doses, even if we achieve 50 to 99% of the target doses, we get almost the same benefit. And we can give the drugs at the minimum possible dose, that also benefits. So the strong HF trial also have shown that if you uptitrate the drugs within 6 weeks, you get the maximum benefit. That is when the disease process is actively on, and that will produce the maximum benefit. And this has become a class 1 indication in the latest European Society guidelines. But it is difficult as we see practically. So what are the factors associated with the non-use and sub-target dosing of medical therapy for heart failure with reduced ejection fraction? Older age, lower body mass index, worsening renal function, low blood pressure, all these contribute to for reasons for non-use of GDMT or sub-target dosing of GDMT. So one of the important factors in the low use of GDMT is clinical inertia. It's a multifactorial problem contributed by healthcare providers, patients, and healthcare system. A failure of the physician to see the importance of achieving the target dose or the maximum tolerated dose remains a barrier. Self-evaluation and implementation of guidelines will help in improving evidence-based care, and heart failure clinic will help in a big way. Self-care behavior among patients, very important. Adherence to pharmacological therapy, exercise, weight monitoring, low sodium diet, all are very, very low in the Indian settings, and clinics can improve this. So what is heart failure clinic? For the regular and systematic follow-up and management of patients with heart failure aimed at improving their outcomes and quality of life. The objectives are ensuring guideline-directed therapy. That is the most important thing. Then protocol-based workup of patients leading to accurate diagnosis. If we have a protocol, we may not miss a diagnosis which may not be that common. Timely referral for advanced care. The complaint by the surgeon is that we refer the patient at a very late stage when the transplant itself is not feasible. So if you have a protocol, we will have a timely referral. And identify those patients who are likely to worsen and prevent readmission. And programming of devices like ICD and CRT, helpline to patients in case of an emergency, what to do, all those things, and data management and research. Do the heart failure clinics benefit? Definitely. This is the meta-analysis of 16 randomized trials which shows that heart failure clinics improves hospitalization and mortality. This is another study published in 2023, small number, but the utilization of GDMT increased from 35 to 85%. It's very significant jump. Ejection fraction improved by 10%, and 6-minute walk distance also improved significantly. So heart failure clinics works. What are the challenges in the Indian situations? Awareness and motivation among patients is very low. Lack of patient education is an important factor. Physician inertia, the knowledge about the need for up titration and the maximum tolerated doses and the target doses, and confidence. If you see a minor increase in creatinine, I think we need not worry. That type of confidence should be built up in physicians. Need for multidisciplinary care, because we need nephrologists, we need sometimes cardiac surgeons, anesthetists. All those things are important. Lack of coordinated care and lack of crosstalk between specialties, economic issues, frequent follow-ups, frequent blood tests, cost of medicines, all is a problem. And heart failure nurse concept is not there in India, and the prescription rate, I will discuss it subsequently. And reluctance to refer to heart failure clinic by the co-physicians, and rehab facilities are not non-existing in India. Then dietitians, counselors are all difficult to arrange. But major hospitals may have it, but it has to be in an organized setup. Who are the patients to be seen in heart failure clinic? Recently diagnosed and discharged after first hospitalization. This is very important. I will tell you subsequently. Those who are readmitted with acute decompensation, very important. Other organ dysfunction, for example, kidney disease, lung disease, we need multidisciplinary care. Those with low blood pressure, which require frequent monitoring, and those requiring frequent IV inotropic support. Components of heart failure clinic, we will discuss about infrastructural, personnel, equipment, processes and systems and database. Who should primarily manage the heart failure clinic? General physician, cardiologist, heart failure nurse, physician assistant, pharmacist, all has been tried in the Western world. But and it has been shown that even a nurse titration of heart failure drugs versus cardiologist titration, actually the nurse titration was better. Nurse-led heart failure clinics, pharmacist-led heart failure clinics have been tried. So in the Indian settings, who should manage? We have the cardiologist or the physician in place anyway there, and most of the places, they start the clinic, they change their one-day OPD to a heart failure clinic. That is the easiest setup to start. And the nurse practitioner concept is not there in India. Nurses cannot prescribe also, but we can train a nurse to be a heart failure nurse, and she can be taught how to follow up the patients, identify the warning signs like a weight gain, patient is not taking the drugs, increase in creatinine, all those things. So she can monitor and inform the cardiologist, and that is how the setup in India can be made. So the key personnel are a cardiologist and physician and the heart failure nurse. Then we should have some people like device programming, surgical team, physiotherapist, dietitian, physiatrist, psychiatrist for depression and anxiety. All these things should be there. But the prime two components are the cardiologist or physician and the heart failure nurse. Equipment, we don't need any elaborate equipments for the heart failure clinic. We need whatever you have in the OPD, you should organize it. That is the only thing which is required. A weighing machine, an echo machine for all hospitals will have a basic LV dimension and function. BNP, point of care device if you have, ECG, BPs, pulse oximeter with the heart rate. You should have a defibrillator when the patient is exercising, and hand dynamometer for assessing the frailty. Simple 5,000 rupees equipment. Physical activity, simple exercises, you can train them, you can have your own protocol, and on chair, just sitting up and sitting from the chair, stretching, one step up and down. And counseling for depression and anxiety is very important because you may not have time as a cardiologist or physician, but you can interest or train your heart failure nurse to provide that. And the specialized care like post-VAD or transplant care, that requires supervision and training. Close echocardiographic monitoring in those situations where early signs of rejection, all those things need specialized care. So systems and processes, evaluation and workup. That is what I said. It should have an established evaluation protocol in your clinic. For example, a patient comes with heart failure with reduced ejection fraction. What are the tests to be done? You may not miss a very rare diagnosis. And cardiac transplant, when to refer, LVAD, these are all special considerations which you have to have a protocol evolved to identify those patients to refer for the specialized procedures. And post-intervention care and follow-up. Functional assessment is very important. Simple, NYHA class, 6-minute walk distance, and I encourage everyone to arrange for a 6-minute walk test in the corridor. Just mark it, and it can be, and our all our patients in our clinic do a routine 6-minute walk test in 6 months, every 6 months. And hand grip dynamometer can be used, very simple equipment. Biomarkers costly, but it may help if your patient can afford. And scores like magic score can be used. Quality of life assessment, even though it is forgotten, it is very, very important. And we have developed our own Indian heart failure quality of life questionnaire, which is widely used. You can use it. Simple one to use. Checklist, very important, very inexpensive. Make a checklist. Make a checklist. Your own hospital. You make your own checklist. There are available checklists available by published by Heart Failure Association, published by European Society. You can modify it to suit your hospital. There are simple tools. For example, checklist discharge, whether you are given all the drugs. When did you ask for the follow-up? Most cost-effective method found to reduce readmissions. And this is one example of a 27-page checklist. The most important question is, when should you do the first review after discharge? Very, very important. Less than 7 days review is the best, because the initial 2 weeks is the period when the patient, after a hospitalization, will have the maximum hemodynamic variations, and the renal function may vary, blood pressure may vary. That is where you have to closely follow. European Society says less than 7 days by the local physician, 7 to 14 days by a physician or a cardiologist. Dietary advice: low salt intake and restricted fluid intake. And it is only in patients who are congested, not in routine patients who are walking around, for a chronic patients who are walking around. Alcohol abstinence, smoking cessation, very important, and provide a balanced, healthy diet is important. Physical activity, this is one area which is forgotten, and we should have our own physical activity program. Class 1A indication, and it improves outcomes. And we have conducted a 2x2 factorial trial, which we are presenting next week in the Heart Failure Society of America meeting, where we showed a benefit with mortality and hospitalization on physical activity in a 2x2 trial. Simple, this is our protocols. And posters, booklets, cartoons, videos, or apps and all, you can make your own, or we can share some of these simple ones to keep in the patient waiting area, so that patients can understand. Some apps can be used. This is our Sri Chitra app, and you can have a database of your patients. So you make a simple Excel sheet of the patient's basic parameters and follow, and you can see the trend. And your patient have a unique heart failure clinic number, contact details, 2 mobile numbers, latest prescription, all those parameters you can include that, and that will help you to see how the patient progresses towards the follow. Follow-up care is very, very important, critical to sustain the heart failure. That is where the heart failure nurse comes in, because you may not be able to do it. So she train the nurse to, if the patient is not coming for follow-up, call them and find out what has happened. All those things will help in improving the guideline directives, where they have taken the drugs, they have done the blood test. So initial visit, as I already said, 1 to 2 weeks. Then every 2 to 3 weeks till 3 months, till drug optimization is done. Once stable, every 3 to 6 months. And always give a helpline number. Your ICU number you can give for 24/7 support. And this is the algorithm for identifying high-risk patients. I need help. So if any of these risk factors are there, you have to closely monitor these patients. Vaccinations, even though neglected, is important. Influenza and pneumococcal. This has been shown to improve the outcomes. How heart failure clinic is relevant in Indian settings? We know that heart failure needs multidisciplinary care. Inputs from specialists like cardiologists, cardiac surgeons, physiatrists, nephrologists, all are required. Heart failure clinics bring them in on umbrella, under one umbrella. So there is an established process to contact these people, to refer to nephrology, like that. It is a system. It is nothing. It is an organized system of what you are doing now. That is what is heart failure clinic. And reduces waiting time, improves interdisciplinary interaction, and adds benefit in reducing morbidity and patient satisfaction. So that is very, very important. And last, before concluding, the University of Ottawa, now they have changed the name from heart failure clinic to heart function clinic. Heart failure as a not a good notation. So to conclude, ladies and gentlemen, Heart failure needs multidisciplinary care. Heart function clinics will bring the comprehensive care under a single entity. Shown to reduce hospitalizations and improve patient satisfaction, will not need big infrastructure and require only few trained personnel like a heart failure nurse. Your own nurse in the OPD you can train. And it is much relevant in Indian settings with overloaded public healthcare or the private healthcare system and huge disease burden. There are challenges, but many of them we can overcome. So I hope many of you will go and start this heart failure clinic process. So thank you for the patient listening, and I'm ready to take if questions or comments. Thank you.
Hello, check. Hello, check. Check. Hello.
Thank you, Dr. Hari Krishnan. I just have a couple of questions. One is, do we have any idea how many heart failure clinics organized we have in India?
We don't have a statistics, but there are many. Our hospital has a heart failure clinic since 2012, and there are some Heart Failure Association of India is coming out with some heart failure clinics. We have already started 45 of them in a pilot phase, and we will be coming out with some more sessions, clinics, and there are so many are actually functioning in India.
So, what's the cost benefit analysis of heart failure clinic guided treatment versus none?
Yeah, there are. I didn't show the slide because of the lack of time. Heart failure clinic has been found to be cost effective. I think at least 3 studies have shown it is cost effective. So it improves the outcomes. It improves the guideline directed therapy and improves the quality of life and even mortality also.
The question was about cost benefit, financial aspect.
Yeah, that is what it is cost effective. It has been found to be cost effective with a simple minor investment. No, you are not investing any. It is only a process, minor modification of the processes. You have checklist, you have a failure nurse, and the additional cost involved is only the heart failure nurse training and maintaining the follow up through telephones and all. There is no additional cost involved. In that case, in that way, it is a very highly cost effective process.
My last question is, how do you see the role of telemedicine, artificial intelligence and machine learning in the home care or hospital care of heart failure patients?
Absolutely, sir. The very, very important point. I actually did miss that. So thank you for bringing out that point. Telemedicine and M-Health and E-Health are the ones which can be very useful in the follow-up of those patients. So now there are many apps being used by the patients, and even a simple telephonic follow-up itself will matter. And just call the patient and say, "Why have you taken the drugs? And have you taken restricted your diet as advised? Do you do a regular physical activity?" All those things itself will help. But telemedicine and e-health and m-health using apps, with the feedback, so they can post there are gadgets available which will measure heart rate, blood pressure, and directly feed to the mobile, which will be transmitted to the headquarters, and the cardiologist can assess and find out those patients who are worsened. So that is a telemedicine, e-health and m-health, as because India has a very good mobile penetration and smartphones have become cheaper. I think it is a very good opportunity for us, all of us, to use that facility.
Dr. Hari Krishnan, and I think just to remind you, we are also involved in one of the program for the distant rehabilitation program for such population, those who are unable to come to our clinic, and is showing good result in last 2,500 patients, very good results in outcome and so far. We have in our hospital, yeah, it's very good.
Absolutely, I think it is amazing the way we did the trial and 1,000 patients, and we got very good results. Mortality and heart failure hospitalization actually improves. We are presenting it next week. So amazing. I think it is. We think that what is there in just one step exercise, stretching and all, but that improves the quality of life and the confidence of the patient. So you are absolutely true, and I think you should publish those data, convince our people that such things helps.
Yeah, thank you. You want to ask a question? We can go to next.
Thank you, Dr. Hari Krishnan. I think we will close your presentation. Thank you very much
for
your time.
Thank you for allowing to come online. So thank you for allowing to come online, and thank you the chairpersons and the organizers. Thank you so much.
We appreciate. Thank you.
Thank you, sir.